Thank you. Our next speaker is Jedd Wolchok, who's Chief of Melanoma and Immunotherapeutic Service at Memorial Sloan Kettering.
Thank you, Malcolm, and thank you for the invitation to this excellent workshop. I think that Rami provided a great introduction for the need for education, specifically around managing adverse events. I think the context to put this need in is really the idea that this field has come a very, very long way in a remarkably short time, and that there are actually only a few people who have substantive experience until very recently, probably because until the past few years, not many folks believed that this area was worth investing time in. I'm proud to say that myself and some others in the room stuck with the field for a while, and it has really lived up to our expectations. Personally, I think you know when your field actually achieves something is when your own organization chooses to advertise it on the side of a New York City bus. So that's the way that I'm feeling these days. But I just wanted, this is just a brief outline of the couple of moments I'm going to spend here on the need for professional education, because there really is a need. There is a very multi-pronged effort among many organizations, which I'll talk about later, to provide for that need. And this is really because this approach to cancer therapy is unlike many other approaches. The types of toxicities, as you've just heard about, are different. The types of clinical responses are different, and the wider oncology workforce needs to know this. So the background here, the change of paradigm really was the development of ipilimumab, which, as you know, works by disinhibiting T cells based upon alleviation of the activity of a molecule called CTLA-4, which normally restrains T cells from becoming hyperactivated. And if you share this with most physicians or nurses, their eyes will probably glaze over because they were probably ignoring immunology in medical school. And that's just a sad fact. And so for our patients, we've actually developed, and family members, this tool of the driving of an immune response, which is something that I think most folks are aware of, that there are multiple steps required to get a car started, and there are multiple steps required to get an immune response activated. And if we understand the individual parts of this and equate, say, CTLA-4 and PD-1 with the brakes, then I think that provides a convenient framework, not just for patients and their family members, but also for physician colleagues who might not have as much experience with immunotherapy to begin to understand this and explain it to their patients. So I think that this is really the first step in education, is being able to explain the details of this new field. As you know, as Rami just very nicely spoke of, the toxicities for immunotherapy are really unlike what we're used to seeing from other standard anti-cancer therapies. The rules for managing these side effects are now very well worked out, but the ones in red on the bottom are really all that a physician needs to know. You need to talk with and listen to your patients. You also need to understand that these toxicities need to be managed mechanistically and not symptomatically. That's actually critical because in the example that Rami gave of the enterocolitis, we actually saw that if patients were managed just with anti-motility drugs symptomatically, like you would for other anti-cancer therapies, that patients could die from intestinal perforation. So there needs to be an in-depth understanding of the mechanism so that the toxicities can be managed appropriately. Time courses are also very helpful in terms of education, and Rami shared this same type of data with you just now, but I think giving patients and colleagues an understanding of when certain side effects might arise allows for them to be managed more effectively. The other area which is remarkably different for this type of therapy is the type of clinical response that was seen. And when we actually look back at the primary data from mouse studies supporting the development of anti-CTLA-4, we can actually see the beginning of this atypical response phenomenon in these studies, which were done by Jim Allison and published now 20 years ago. So this is just showing that mice treated with anti-CTLA-4 all have tumors grow before they eventually regress. And this data would actually predict what we saw in patients when they were first treated with anti-CTLA-4, such as this patient of mine who had fulminant radiographic progression in the liver after 3 months of therapy with anti-CTLA-4, only to be followed by a very significant regression without any intervening therapy between weeks 12 and week 20 here. So we learned that you cannot depend upon empiric time points in order to determine response. And this is really important in managing expectations in patients and their families, and actually physician colleagues who may be calling and asking for advice as to when to change therapy. The other examples, this is another well-published example of a patient with skin metastases that were very clearly progressing at week 12, and then when this patient went on to have a complete response. So I think we, together with our colleagues at BMS at the time, we began to categorize different responses to immunotherapy. We began to put them into different categories. Some of them were conventional. Others were really novel for immunotherapy. I had the great privilege of actually working with Rami on this many years ago. And we began to plot out different changes in tumor burden that happen in patients, which make them actually very difficult to categorize by standard RECIST or WHO response determinations, because they can have new lesions while the index lesions are regressing. They can have transient periods of progression before objective response. And this makes the data from these clinical trials remarkably complex unless you use overall survival or landmark survival as an endpoint. So based upon this, we dug into the database from the phase 2 trials of ipilimumab and looked at the response adjudications from all of these melanoma patients who were treated with a standard dose of ipilimumab. At the time, it was 10 milligrams per kilogram. As you know, the dose is lower now. And what we found was that there are probably 10 to 20% of patients who will progress on the first set of scans by standard imaging guidelines, who will then go on to have some determination of response without any additional anti-cancer therapy. And so that's very important to know as you're advising patients and their families and other physicians about the need for additional therapy. We developed a set of guidelines called the immune-related response criteria, which try to incorporate these different response kinetics by suggesting that patients have confirmatory scans for progression when they're not symptomatically progressing, and also for stopping the use of new lesions as sole criteria for progression, and instead looking at total tumor burden. And if you do that, you identify this group of patients on this dark blue line who were previously in the line of progressors, who actually end up doing, in terms of long-term survival, just as well as the patients who respond on schedule at week 12. So we see that long-term outcomes can, in fact, be pretty accurately predicted with the use of these atypical response kinetic guidelines. Just to give you an idea, we applied these to the anti-PD-1 drug development plans as well. I don't need to give too much introduction to anti-PD-1. There are responses that are seen in melanoma, and even in some of the first studies of nivolumab here, you can see patients having clear atypical responses with growth preceding regression, new lesions appearing here indicated by the red triangles, even in patients who went on to have a complete response. So with colleagues from Merck, we went on to look at this and presented this at ASCO last year, looking at the appearance of atypical responses in patients treated with pembrolizumab for not just melanoma, but for other tumors as well. This is an example of a patient with melanoma who showed a clear increase in tumor burden at week 4, which eventually regressed. This is a patient with non-small cell lung cancer, also who had an increase at week 9, followed by an improvement. So the likelihood of one of these atypical responses occurring is actually less with PD-1 than with anti-CTLA-4. It's probably about a 5 to 10% sort of incidence of atypical responses, but it certainly can happen. And this is the same type of curves showing these atypical response kinetics seen here with pembrolizumab that we also saw with ipilimumab. You can also see delayed pseudoprogression with patients who will have transient increases in tumor burden after having a response. And with just continued therapy, you can see that these areas of progression may not be sustained, and that this also translates into better outcomes. So to finish up here, there's a clear rationale for broad-based education efforts in this field. And this is not just because myself and my colleagues are really getting exhausted, because we go to a lot of meetings and try to actually educate colleagues, but I think that we need to train the next generation of oncologists to understand immunotherapy and to be able to apply these lessons, as now immunotherapy is another standard pillar of anti-cancer therapy. We need to really have well-grounded physicians and nurses in this area. And so there's obviously these two areas that I stressed, and I just want to highlight some of the organizations that have already entered this space. Really for the longest time, the Society for the Immunotherapy of Cancer, or SITC, has identified this need and has responded to it quite vigorously, both with training sessions as part of their annual meeting, as well as a very well-attended immunotherapy primer session, which is organized by some of the folks in this room in the past, Bernie Fox and Lisa Butterfield. This really provides very needed education for physicians who don't have experience with immunotherapy. They also have what some of us have termed the Roadshow, or the ACI, for the Advances in Cancer Immunotherapy, which brings this type of education in cancer immunotherapy to various locales around the country to make this more convenient. I've participated in these, and they're very well attended, and they provide a very, very needed resource. There are other areas. There are some videos that have been put up involving lung cancer by SITC, some online CME activities, and a mobile education activity that can be used on the phone. Other organizations which are in this area, ASCO has now made a very firm commitment to this, recognizing that cancer immunotherapy is the breakthrough of the year. It represents a radical departure from existing treatment paradigms. There are many new agents rolling out, and there's literally a flood of information for people to integrate. So ASCO has done this in several very meaningful ways. First is to integrate immuno-oncology into its ongoing education programs, including ASCO University, and the establishment, importantly, of collaborative sessions both at the ASCO annual meeting and with SITC at the SITC annual meeting. There is also now announced the launch of an ASCO-SITC Clinical Immuno-Oncology Symposium, the first example of which will be in early 2017. So there are various ASCO University courses. These are online courses that ASCO offers as part of its educational efforts in cancer immunobiology, classes of immune agents, and the other items mentioned here. As I mentioned, ASCO is collaborating heavily with SITC in this area. There is a hot topic session on value that was conducted at the 2015 SITC meeting. There is a session on how to integrate tumor immunotherapy into a physician's clinical oncology practice, which will actually be featured at this year's ASCO annual meeting. And the ASCO Value Summit also will have attention paid to this important area. The ASCO-SITC Clinical Immuno-Oncology Symposium, as I mentioned, will roll out just under a year from now in Orlando, Florida, and I think will be a very important addition to the ongoing education efforts. The Cancer Research Institute has also made a commitment to this area. My very handsome colleague, Dr. Postow here, doing one of their video webinars for oncologist to oncologist training on how to treat your patients with immunotherapy. Also, CRI has made a commitment to oncology nurse education and is working collaboratively with the Oncology Nursing Society to enhance educational efforts with that group as well. There are also online resources that CRI has offered in its Answer to Cancer program. And then finally, there is an immuno-oncology policy working group which just met about December 2015. This is led by the Friends of Cancer Research, Pfizer, and EMD Serono, representatives of which are here, and many stakeholder participants. It was a very important session, and just to highlight among the topics that were discussed, the last one bulleted here is Immuno-Oncology Education Initiative, also clearly demonstrating the importance of this area and now a focus of this IO policy working group. So really, I can't stress enough how important it is to have these other organizations that have made a commitment to educating physicians, nurses, other treating colleagues in this important and growing area. Thank you very much for your attention.